let us talk about episcleritis. As the word suggests, episcleritis. So this is inflammation above the main sclera. So this is recurrent, benign, idiopathic inflammation of episclera and the Tennant's capsule covering it. As you can see in this picture, can you see superficial blood vessels? So what happens is that in this case, due to inflammation, superficial vascular plexus, when I told you about the blood supply, so superficial vascular plexus, that is involved. So how would the patient come to your clinic? Patient would come to your clinic and he says that, sir, I am getting this redness of the eye. So this is a differential diagnosis of red eye. What are the other conditions which can cause red eye? Like uveitis, even your conjunctivitis, even in the patients who are having a keratoconjunctivitis. So in all these cases, you can have a red eye. So when the patient is having an episcleritis, the superficial vessels are involved and you would see bright red pattern, as you can see here. There is a bright red pattern of the vessels that are involved. Usually the patients are young females, approximately around the age group of 35 to 45 years, and they have a good immunity. Okay, so that's why these patients, though it is idiopathic, many patients have an association with gout or rosacea and or any autoimmune disorder, and even some infections like Lyme disease, herpes zoster ophthalmicus. They can also be a correlating associations in the patients of episcleritis. Now, how to differentiate a patient of episcleritis with other similar type of disorders like scleritis? So we would be talking about the scleritis later, but as the word suggests, the scleritis is basically the inflammation of the sclera proper, your stroma and the lamina fusca that is involved. So when you are having a episcleritis where there is a superficial vessels that are only involved, so very important diagnostic test which was asked last year, that can be done. That is 10% phenylephrine solution, eye drops that we put over the eye, and that causes a blanching of vessels. So from the red eye, it becomes white. Why? Because only the superficial vessels are involved. Few words regarding the management. So management is just you have to tell the patient to reassure the patient that it would go on its own. And in the cases where the patient comes and he says that, sir, this redness is bothering me, there is a more of a foreign body sensation and mild pain, because there are not much conditions or much symptoms in the patient. The patient does not feel too much of pain. He is not very much concerned about this. So only in those cases which are having a mild episcleritis, you want to basically get rid of the symptoms, you can use mild NSAIDs like napafinac, floribrofan, or you can use soft steroids like loteprednol or fluorometholone. Okay, and for the redness, you can basically give the phenylephrine solutions with nefazoline to decrease the amount of redness. So these are the important points you should remember regarding the episcleritis, that this is the superficial inflammation, and this type of inflammation that is basically self-limiting and you do not need to treat it aggressively. The patient does not have many symptoms and there is no visual threatening condition, that is episcleritis. Now we move to more dangerous type of inflammation, that is scleritis. As the word itself suggests, this is the inflammation of sclera proper. Unlike your episcleritis, the patients with scleritis can have more catastrophic visual complications. The patient of an episcleritis comes with just a mild foreign body sensation, a redness, small amount of watering or mild pain. But the scleritis patients, they come with lot of pain. When we see its appearance, when the patients come with just an episcleritis, I told that there is a superficial vascular congestion. But when we have a patient of scleritis, in these patients we have deep vascular plexus that is involved. So this was a question few years back where they talked about the difference between your scleritis and episcleritis. So remember, in scleritis there is a deep vascular plexus involvement, and in episcleritis there is a superficial vascular plexus involvement. Now whenever we have a patient of scleritis, as I told you, in episcleritis you may be having a young female that is presenting to you. In scleritis, they would give you that a 50-year-old female came to the OPD. She is having a history of rheumatoid arthritis and she is having a severe pain in the eye. Okay, so what are the important glitching factors? That the patient is usually middle to old age, in contrast to your episcleritis, female. Now both in the episcleritis as well as in scleritis, it is more common in female, and association with rheumatoid arthritis. Now this is very important. This has been a question beforehand also, that in patients of rheumatoid arthritis, if they ask what is the very important ocular complication, it is your scleritis. Now this disease, scleritis, is associated with other autoimmune diseases as well, like you have SLE, polyarteritis nodosa, vaginal granulomatosis. Even in the conditions like VKH, we can have ocular complication, that is scleritis. Okay, so these are some important points regarding the scleritis. Now let us learn what are the various types of scleritis and how to differentiate a patient of scleritis with episcleritis. So first of all, 2 points which I repeat once again. So if we have to basically differentiate between a patient of scleritis and episcleritis, with the 10% phenylephrine solution, there is no blanching. When we see on the slit lamp, the color of the sclera, that is more violet color. Okay, in that case there is a more of a reddish color congestion. Here there is more deeper congestion and there is a violaceous hue that comes from the sclera. So that is how you can differentiate from just an appearance regarding sclera and episclera. Okay, now we come to what are the types of scleritis. So we differentiate into 2 types. anterior and posterior. So anything, let's say this is my eyeball, this is the equator. So inflammation that is anterior to equator, I call it anterior scleritis, and the inflammation of sclera which is posterior to the equator, that is called posterior scleritis. Okay. Now, whatever I have told you, violaceous hue, there is a deep vascular plexus involved, so that we all can see only in the anterior scleritis, because in posterior scleritis you cannot basically see the posterior sclera. Okay. So when we come to the anterior scleritis, what is the different type of anterior scleritis? Now they can be differentiated into non-necrotizing and necrotizing. Okay, so necrotizing means that now the collagen fibers, they are getting necrosed and the sclera is becoming thinner and thinner. So when we talk about non-necrotizing, it can be further divided into diffuse or nodular, and the necrotizing can be with inflammation. So it can be something, let's say the patient is having vaginal granulomatosis and you are having an inflammatory necrotizing, or without inflammation. Now, if it comes without inflammation, that is very important. Why? We would study it later. And when we talk about the posterior scleritis, so here we are having the sclera which is posterior to equator, that is involved. So this is the basic classification. You understand? Now few words regarding the scleromalacia perforans, which was a previous year question. Now here, as you can see in this picture, the sclera is white. There is no inflammation. But as you can see here, there is a scleral thinning, and because of the scleral thinning you can see the uveal tissue as well. Okay, so this can also be confused with staphyloma. But how they would give you a question, that they would give you a question, patient is having a history of rheumatoid arthritis, and with rheumatoid arthritis they would say that patient is a middle-aged female, she is having this kind of picture. So your answer becomes more in according to scleromalacia perforans as compared to a staphyloma, that is a ciliary staphyloma. But if they give a question, let's say the patient is having a absolute glaucoma, or he has undergone a trabeculectomy surgery, and then you are seeing protrusion of uvea through that area, then your answer becomes more in the diagnosis of your ciliary staphyloma. So the question, whenever you get a MCQ based question, you have to basically see all the hints, and after seeing all the hints you compare which one is having a more probability as an answer. So the very important point here is the association with rheumatoid arthritis and white sclera and the uveal tissue that you can see from outside, because there is a thinning of overlying sclera. These are important points regarding the scleromalacia perforans. Now we come to the posterior scleritis. As I told you, what would happen here is that there would be inflammation of sclera, and because of this inflammation of sclera, when we do a ultrasound B scan, there would be certain features. So the first feature would be that there would be increase in the scleral thickness. Okay, this is very important. Sometimes you can see scleral nodules as well, but very important here is the presence of a sign which is called T sign. Now, why a T sign happens? So look like this is a T. Okay, so this is a T where there is a, because of the fluid collection, because of the inflammation, there is a fluid collection between the sclera and the Tennant's capsule, and this is the shadow of my optic nerve head. Okay, so this T sign is indicative of diagnosis of posterior scleritis. Now this inflammation can go in the choroid as well, so there may be chances that it may seep up to the retina as well, and there may be inflammation of the optic nerve as well, so you may have disc edema. One more question they have asked is that can you get a retinal detachment in the patient of posterior scleritis? So definitely yes. So the patient may have exudative retinal detachment in these cases. So these are some important points you should remember regarding the posterior scleritis, and as the condition is more severe, so that's why whenever you are having a scleritis or anterior or posterior scleritis, the management is more aggressive. You have to start with immunosuppressive therapy, where initially you can give corticosteroids, but in the later half you have to basically use more potent agents like azathioprine or cyclophosphamide. So that's why it is more important, because in conditions like scleromalacia perforans, there can be a spontaneous rupture of the eyeball as well, and that is very catastrophic for the patient. So these are some important points you should remember regarding scleritis, anterior and posterior scleritis.